This is Med Central's Not Quite Curbside GI Consults. I'm your host, Dr. Alexa Mieses Malchuk, and today we're discussing a condition that I see all the time in my practice, acid reflux. We'll be talking with gastroenterologist Pratima Dibba. Pratima, it's so good to have you here on the podcast.
Well, thanks so much for having me.
All right, so acid reflux. I'm sure it's something you see all the time as well.
Yeah, every single day.
Super common. And
Yeah.
I'm wondering if we could just start with really the basics. So, what is the difference, in your mind between just occasional acid reflux versus true GERD or gastroesophageal reflux disease? How do we differentiate between those two things?
It really depends on the presenting symptoms, the chronicity of symptoms. Obviously the two overlap, but if symptoms are occasional, there may be, fewer consequences to not treating with a daily type of medication. Obviously, ongoing reflux, or, chronic symptoms can always have consequences, whether that's, interruption of daily living, and quality of life, or even changes in the esophagus. We always get concerned about possible precancerous conditions like Barrett's esophagus, which would be a consequence of uncontrolled reflux if symptoms are pretty frequent.
Yeah, I would say starting off really basic, thinking about our patients, they'll come in and they'll
Mm-hmm.
say, "Oh, I have heartburn." Right? So how do we
Mm-hmm.
differentiate between, you ate something that triggered some acid reflux
Mm-hmm.
versus someone who has true disease? And I think what
Right.
I'm hearing you say is that the frequency and the chronicity of it really plays a
Mm-hmm.
role. So if someone's having frequent and chronic acid reflux, then we might put them in that category of GERD. Is that right?
Yeah, there are a lot of dietary triggers that can trigger occasional symptoms. If you're drinking a lot during holidays, you've been drinking a little more caffeine recently with work assignments, just some occasional acute symptoms that resolve just with lifestyle modifications, and that's something that you can treat just symptomatically with maybe famotidine as needed, lifestyle modifications. But when people have just chronic and recurring symptoms, that's really when they should be evaluated for either any underlying conditions or risk for some sorts of conditions that they may be predisposed to. For example, if you have a patient who's a smoker, a heavy drinker, somebody who has just really uncontrolled symptoms, people who are on NSAIDs frequently, then you have to worry about, hey, is this patient somebody who requires further evaluation? Is this person going to need more medications just a Tums or a Pepcid over the counter as needed?
Yeah, so I'm kind of hearing two different things. So on one hand, it sounds like there are some things that might, increase the likelihood of someone having acid reflux or the frequency, sort of predisposing factors. And then there are those complications from uncontrolled reflux that we have to worry about. So I guess if we're just thinking about that first piece, what are some risk factors for GERD? What are some of the things that we might see commonly?
Yeah, absolutely. The most common ones that I see are caffeine, number one. Don't we all
Oh,
overdose on
good old
caffeine?
caffeine.
Or yeah, and like any form of caffeine. A lot of people kind of downplay their amount of caffeine because they forget that there are a lot of things that contain caffeine, not only coffee. So that's frequent alcohol use, any form of smoking or vaping, whether that's tobacco or marijuana, then spicy foods, citrus foods, carbonated beverages, tomatoes, garlic, chocolate. These are all kind of day-to-day things that we consume in frequency. You don't seem like they would really cause any major issues, but can truly cause not only reflux, but some of them can cause actual damage in the lining of the stomach. The other one that's a huge risk factor is anti-inflammatory meds. Obviously, a lot of non-steroidal anti-inflammatories are available over the counter, and it's easy for a lot of people just to use them chronically for pain or any non-specific. And a lot of people just use them in frequency without realizing that that can actually not only trigger symptoms of reflux, but can ultimately induce an ulcer, which can sometimes present as reflux. And that'll include Motrin, ibuprofen, Excedrin, Aleve, meloxicam, naproxen, Advil, any variation of those meds.
Yeah. So I'm hearing that basically what we eat what we drink, some of the medications that we take can really all cause acid reflux. I think
Hmm.
another thing that I see in my own practice is stress as an exacerbator of acid reflux. And I'm wondering if you can talk a little bit more about some of the sort of mechanical or anatomic risk factors for acid reflux. So, thinking about things like maybe a hiatal hernia, or having extra abdominal fat, laying flat, after you eat. How do you typically counsel patients about those sorts of things?
So the mechanism by which we think reflux occurs is really a loosening of the esophageal sphincter. And, all of the kind of things that we consume obviously contribute to that, but anatomic feature or an anatomic defect like a hiatal hernia, where a little bit of the stomach pouches into the esophagus, can predispose somebody or make somebody at risk for more frequent symptoms. Obesity is a risk factor for chronic reflux disease. So right now in our guidelines, it's actually recommended that if somebody has a BMI over 25, obviously to work on weight loss. And then some lifestyle modifications that can just optimize management of these include, elevating the head of the bed 30 to 45 degrees, trying to avoid eating within 3 hours of lying down, and then kind of avoiding some of the high risk foods.
So lots of things can cause acid reflux. So I assume that's why it is so common. But what I'm hearing you say is that if a person has true GERD or, esophageal reflux disease, then we should really be looking out for those complications. Now, in my practice, I think about ordering an EGD or an endoscopy to take a look at that. But can you tell me a little bit more about the decision making that goes into, does my patient need an endoscopy or not?
Yeah, actually, that's a very interesting topic because, the guidelines and, obviously insurances have some say in the way we approach endoscopies. But there are a couple of approaches to this. I mean, I really think that it depends on the extent of symptoms. You have to really pay attention to whether or not there are additional features that indicate that something else is going on, like eosinophilic esophagitis, for example. People have occasional heartburn, but they're actually feeling like they felt like food is actually lodged in their esophagus. That is not something that's just typical reflux. You also want to make sure that there's no just overt alarm features, loss of appetite, early satiety, weight loss, severe nausea and vomiting, any sort of difficulty swallowing, pain on swallowing. These are all indications that you really shouldn't take a chance when it comes to the endoscopy. But if it's just, somebody, again, a low risk patient with just, hey, I just get heartburn every single day. I drink a ton of coffee, or, I've been drinking a little bit more during the holidays, something like that, you can trial them on just a PPI and then go forward from there. I do have quite a few patients who prefer to actually look inside before they commit to a medication. All of those things really contribute to decision making.
Got it. So, for anyone who's having what we would call those alarm signs or symptoms, so you mentioned a bunch of them, but severe nausea, vomiting, weight loss, having trouble swallowing, they certainly need an endoscopy, it sounds like. But for your run of the mill sort of, GERD, it's okay to do a trial of a PPI medication first, unless, of course, the patient prefers otherwise or, insurance tells us otherwise. Sometimes
Yeah,
that's just how it
it is
goes.
what it is. Yeah.
Yeah. So I think the other thing I would love to hear you talk about is what are some of those symptoms? I think we've been alluding to it kind of throughout this conversation, but can you tell me sort of what are the classic signs and symptoms of acid reflux?
Right? Heartburn, regurgitation, feeling like food is getting at the stuck at the base of your throat. That's called globus. But you also have to consider some atypical symptoms that are often confused with other comorbidities, things like mucus clearing, a funny taste in the back of your throat, an abnormal cough that all of a sudden started. Sometimes you can get features that are a little bit confusing, chest pain, shortness of breath. That's often something that I see, but obviously, or or excluding any sort of cardiac or pulmonary comorbidity is really important in cases like that.
Yeah. No, that's really great to hear. I guess thinking back to the endoscopy, how do you counsel patients about some of the risks, benefits, and alternatives to undergoing endoscopy?
I usually offer patients a non-invasive approach when there are no over alarm features, and it really, if again, if there's nothing that signifies that maybe there's an underlying issue going on, that's usually the first line. And again, if it's a patient preference and insurance is permitted, I'm happy to offer an endoscopy at the same time. But I mean, if that's their preference. But usually, what I do is I start off with gauging what lifestyle risk factors they have, offering the two types of medications. Some people still have that stigma about PPIs because of all that bad data, which we can discuss also. And then the endoscopy, obviously, if they have refractory symptoms, develop any severe alarm features, or have them to begin with, I would go towards that route.
And how frequently do you recommend repeating an endoscopy? So, say you have someone, they have GERD, you did the first endoscopy, you didn't really see any signs of Barrett's esophagus or anything else alarming, but they haven't been able to trial off of a PPI, their symptoms recur, they're doing all they can in the way of lifestyle, but still the symptoms really aren't getting better unless they're taking that PPI every day. At what interval would you repeat the endoscopy?
So it really just depends on the patient and what risk factors they have for any sort of like precancerous conditions, whether or not they have any new features. But truly, there's no guideline where you need to give them surveillance endoscopies for GERD itself. I mean, if I were to find a major ulcer that's masquerading as GERD, then there are guidelines where you should perform ulcer surveillance when you have LA grade C or LA grade D esophagitis, like very advanced esophagitis, that again can present as just plain old reflux. You should take a look back in. So it really depends on what you're seeing, but just for symptoms with a pretty normal endoscopy, there's no actual surveillance interval.
Got it. And where do things like H. pylori and sort of, other causes of GERD type symptoms, where do they come in and play a role?
So, to be honest, I test everybody for H. pylori when they come in for reflux, and it's a hit or miss with that. Typically, H. pylori really presents as like kind of dyspepsia, abdominal discomfort, not always typical reflux, but more often than not, I find that patients have H. pylori, and sometimes when I treat it, symptoms just significantly improve. And I'm able to do non-invasive testing, so when that's available, that's great. Either breath testing or stool testing. Obviously, patients don't really like stool testing, but if I'm lucky, I have the H. pylori breath testing. And then if they do an endoscopy, we test for it there. So I just do it as a standard baseline whenever anybody presents with reflux.
Yeah, can you talk a little bit? I mean, I guess this is my own bias coming in. I'm a big fan of the stool antigen test for H. pylori, but of course, I recognize not all patients love to collect their own stool sample. So, can you talk a little bit about the specificity and sensitivity of the different types of tests for H. pylori? Because that's certainly something that comes up in primary care practice all the time.
Yeah, absolutely. So breath testing and stool testing, they still have a pretty good sensitivity and specificity, but obviously histologic diagnosis is actually like gold standard for H. pylori. So while they're pretty good at detecting H. pylori or excluding it, there's still a small margin of errors.
That's good to know. So maybe I'll do more breath testing with my patients, since with my patients if they prefer it. Okay, so this is a really big, important question I do want to dig into a little bit, which, you kind of mentioned earlier about the data on long-term use of PPIs and the risks with that. And this comes up in primary care all the time. We'll have a new patient. I had a patient recently who was in her 60s, had been on a PPI for quite some time, at least, over a decade. And, when I asked when was your last endoscopy, do you have Barrett's esophagus, just really trying to understand why she was on this for so long. She couldn't really tell me, and that's okay. That's fine. But, at that point I felt like, okay, maybe we need to do a little bit of digging to see if number one, you still need this medication or not. And number two, if you do need it, like, let's make sure the benefit outweighs any risks. But can you talk a little bit more about what those risks are and how worried should we actually be about long-term PPI use?
Yeah, I'm actually glad that you brought this up because I think it's something that just really needs to be clarified, not only amongst the medical community, but just like patients in general. We're in a day and age in medicine where Googling is the first thing to do. And so a lot of patients like to do their own research which is not a bad thing, but it's a matter of distinguishing between, you know, accurate data and kind of inaccurate data. Now, essentially, the study that was done a couple of years ago about these adverse effects associated with PPIs, it wasn't specifically a randomized controlled trial seeking out these complications. It was kind of like a retrospective observational study where, hey, patients are taking PPIs. and then they have these they have these comorbid conditions, low B12, low magnesium, kidney disease, dementia, all sorts of things. And so that data wasn't solid data for us to really presume that there is an absolute causation as opposed to just like possible
Sure.
association. And because of that, there have been some follow-up studies that have been done. And currently, we really don't find that PPIs absolutely cause any of this in the long term. We think maybe it can contribute to bone loss over many years. That's a risk that is not isolated to PPIs alone, obviously. And so a lot of patients, just because the data's online, will come into me and they'll have a lot of concern about any sort of long-term side effects with this medication, and they're super apprehensive about it. So for most patients, I tell them, hey, I understand the caution you want to take. This is kind of what the data shows, and we can play it by ear. I always give patients to start off with just a 4 to 6 week trial, and then see at that point we can wean off. And every 3 to 6 months, I just reevaluate if we can get them off of the medication more, to just err on the side of caution, obviously, because there is that data out there, but it's very useful at the same time. It controls symptoms really well for people who cannot manage their lifestyle risks. It's great for Barrett's esophagus. It's recommended for Barrett's esophagus. And we use it for ulcer healing. So when there is actual damage that we find on an endoscopy or an ulcer, this is the type of medication that we need. So it's really about weighing out risks versus benefits, and then also catering to what the patient wants, right? Like if a patient doesn't want to be on a PPI, that's okay. We're just going to have to work on some of the other stuff or offer alternatives, basically.
Got it. Got it. Really great information. So let me ask you, we covered a lot. Tell me, is there anything we left out? Is there anything you really want listeners to know?
Really pay close attention to some of the dietary risk factors that may be contributing to symptoms, and see if you can make any changes. But it's never the wrong answer to just talk to a medical professional. I mean, if you are going to your PCP, mentioning it to them and helping them, or guiding them as to the chronicity of your symptoms, severity of your symptoms, they could really refer you over when necessary to the right specialist, who can do a further workup, but really focus on some of those risk factors that we had mentioned and see if there's small modifications you can do. But it's never the wrong answer to seek medical care.
I was going to say, I know we were wrapping up, but now I have another question for you. I love that you plugged primary care. Yes, all patients should start with their primary care physician and talk
Mhm.
with their primary care physician about acid reflux. There's certainly a ton that we can do in terms of the workup and trialing PPIs and all of that. We could even order endoscopies directly. When do you want us to refer to you? What are some of the things that are an absolute must refer to GI, or maybe some of the things you wish we would have kept among, primary care providers? I'd love to hear your insight on that.
Well, actually, I don't think it's ever the wrong answer, even for plain old reflux, to have a patient sent over. But I think the alarm features are really when a patient absolutely needs to see a gastroenterologist. I mean, if it's just basic heartburn here and there, that's occasional, and they're pretty low risk and they're doing really well with lifestyle modifications or just a PPI or as needed medication, then it's definitely within the realm of a PCP. But at the same time, it's never the wrong answer to kind of just send them over symptoms. I mean, I do have a lot of patients who live with eosinophilic esophagitis for years, and they're like, oh yeah, there was just that one time I was in the restaurant trying to make myself, vomit up food that was stuck in my esophagus, and then completely forgot to reveal that to their PCP. So I think it is never the wrong answer to send them earlier than later. But if you feel like patients are really doing well with lifestyle modifications, and whatever medication you see fit, then you feel comfortable managing it, then that's not the wrong answer.
All right. Pratima, thank you so much for your
Sure.
time. A lot of really good information.
Yeah, absolutely. Thanks for having me.